Hepatic encephalopathy and coma. Hepatic encephalopathy, a life-threatening complication of liver disease, occurs with profound liver failure and may result from the accumulation of ammonia and other toxic metabolites in the blood. Hepatic coma represents the most advanced stage of hepatic encephalopathy. Some researchers describe a false or weak neurotransmitter as a cause, but the exact mechanism is not fully understood. These false neurotransmitters may be generated from an intestinal source and result in precipitation of encephalopathy. Many other theories exist about the causes of encephalopathy, including excess tryptophan and its metabolites and endogenous benzodiazepines or opiates. Benzodiazepine-like chemical compounds have been detected in the plasma and cerebrospinal fluid of patients with hepatic encephalopathy due to cirrhosis. Portal systemic encephalopathy and most common type of hepatic encephalopathy occurs primarily in patients with cirrhosis with portal hypertension and portal systemic shunting. Pathophysiology. Ammonia accumulates because damaged liver cells fail to detoxify and convert to urea, the ammonia that is constantly entering the bloodstream. Ammonia enters the bloodstream as a result of its absorption from the GI tract and its liberation from kidney and muscle cells. The increased ammonia concentration in the blood causes brain dysfunction and damage, resulting in hepatic encephalopathy. Circumstances that increase serum ammonia levels tend to aggravate to or precipitate hepatic encephalopathy. The largest source of ammonia is the enzymatic and bacterial digestion of dietary and blood proteins in the GI tract. Ammonia from these sources is increased as a result of GI bleeding, that is, bleeding esophageal varices or chronic GI bleeding, a high protein diet, bacterial infections, and uremia. The ingestion of ammonium salts also increases the blood ammonia level in the presence of alkalosis and hypokalemia. Increased amounts of ammonia are absorbed from the GI tract and from the renal tubular fluid. Conversely, serum ammonia is decreased by elimination of protein from the diet and by administration of antibiotic agents such as neomycin sulfate that reduce the number of intestinal bacteria capable of converting urea to ammonia. Other factors unrelated to increased serum ammonia levels that may cause hepatic encephalopathy in susceptible patients include excessive diuresis, dehydration, infections, surgery, fever, and some medications. That is, sedative medications, tranquilizers, analgesic agents, and diuretic medications that cause potassium loss. Clinical manifestations. The earliest symptoms of hepatic encephalopathy include minor mental changes and motor disturbances. The patient appears slightly confused, has alterations in mood, becomes unkempt, and has altered sleep patterns. The patient tends to sleep during the day and have restlessness and insomnia at night. As hepatic encephalopathy progresses, the patient may be difficult to awaken. Astrictis, that is flapping tremor of the hands. ASTERIXIS, asterisk. Simple tasks such as handwriting become difficult. A handwriting or drawing sample, that is example star figure, taken daily may provide graphic evidence of progression or reversal of hepatic encephalopathy. Inability to reproduce a simple figure is referred as a constructional apraxia. Apraxia, APRAXIA. In the early stages of hepatic encephalopathy, the deep tendon reflexes are hyperactive. With worsening of hepatic encephalopathy, these reflexes disappear and the extremities may become flaccid. Assessment and diagnostic findings. The electroencephalogram (EEG) shows generalized slowing and an increase in the amplitude of brain waves and characteristic triphasic waves. Occasionally, fetal hepaticus, that is, a sweet, slightly fecal odor to the breath perceived to be the intestinal origin may be noticed. The odor has also been described as similar to that of freshly mowed grass, acetone, or old wine. Fetal hepatitis is prevalent with extensive collateral portal circulation in chronic liver disease. In the more advanced stage, these are gross disturbances of consciousness and the patient is completely disoriented with respect to the time and place. With further progression of the disorder, the patient lapses into frank coma and may cause seizures. Approximately 35% of all patients with cirrhosis of the liver die in hepatic coma. Medical management. Lactulose is administered to reduce serum ammonia levels in acts by several mechanisms that promote the excretion of ammonia in the stool. Ammonia is kept in the ionized state, resulting in a fall in colon pH, reversing the normal passage of ammonia from the colon onto the blood. Evacuation of the bowel takes place, which decreases the ammonia absorbed from the colon. Third point, the fecal flora has changed to organisms that do not produce ammonia from urea. 2 or 3 soft stools per day are desirable. This indicates that lactose is performing as intended. Possible side effects include intestinal bloating, cramps, which usually disappear within a week. To mask the sweet taste to which some patients object, lactose can be diluted with fruit juice. The patient is closely monitored for hypokalemia and dehydration. Other laxatives are not prescribed during lactose administration because their effects would disturb dosage regulation. Lactulose can be administered by nasogastric tube or enema for patients who are comatose or in whom oral administration is contraindicated or impossible. Other aspects of management may include intravenous administration of glucose to minimize protein breakdown, administration of vitamins to correct deficiencies, and the correction of electrolyte imbalances, especially potassium. Additional principles of management of hepatic encephalopathy include the following. First one, therapy is directed toward treating or removing the cause. Second, neurologic status is assessed frequently. A daily record is kept of handwriting and performance in arithmetic to monitor mental status. Third, fluid intake and output and body weight are recorded each day. Fourth, vital signs are measured and recorded every 4 hours. Fifth, potential sites of infection, that is peritoneum, lungs, are assessed frequently and abnormal findings are reported promptly. Sixth, serum ammonia level is monitored daily. Seventh, routine intake is restricted in patients who are comatose or who have encephalopathy, that is refractory to lactulose and antibiotic therapy. Eighth, reduction in the absorption of ammonia from the GI tract is accomplished by the use of gastric suction, enemas, or oral antibiotics. Ninth, electrolyte status is monitored and corrected if abnormal. 10th, sedatives, tranquilizers, and analgesic medications are discontinued. 11th, benzodiazepine antagonist, that is flumazenol, may be administered to improve encephalopathy whether or not the patient has previously taken benzodiazepines. Nursing management. The nurse is responsible for monitoring and safe environment to prevent injury, bleeding, and infection. The nurse administers prescribed treatments and monitors the patient for many potential complications. The nurse also communicates with the patient's family to keep them from informed about the patient's status and supports them by explaining the procedure and treatments that are part of the patient care. If the patient recovers from hepatic encephalopathy and coma, rehabilitation is likely to be prolonged. Thus, the patient and family will require assistance to understand the causes and the severe complication and recognize that it may recur. Thank you.